Um, okay, so it's now 11:01 on my watch, so maybe we'll start. Welcome to you all to this session about social prescribing and employment. My name is Marcello Bertotti. I'm a reader in community health at the Institute for Connected Communities at the University of East London. And I've been, doing research on social prescribing for a number of years, research, training and evaluation. And I'll leave it there and I'll pass you on to Tony, who's the other chair, and let Tony to introduce himself to you. Over to you, Tony, for introduction.
Hello, good to see you all. My name is Tony Doherty. I'm from Derry in the north of Ireland, and I work for the Healthy Living Centre Alliance, and I'm the co-chair of the Social Prescribing Network Ireland, which is all Ireland network. So it's very good to see you, and I'm looking forward to the discussion.
Thanks, Tony. So before we start, could I ask everybody? Before we start, I will explain the structure of the session and introduce the topic and so on. But before I do that, could I ask people to please mute themselves so that we can all hear, and also post questions in the chat room. We have about 5 presentations, about 6 minutes each. So the plan is to run each presentation one by one. We'll do that in a minute. And please, as I said, post questions in the chat, and also perhaps if you see some questions that you like, click on the like, so that will help us to kind of shortlist the questions, and because we might not have enough time for all the questions to be answered by our panel. Obviously, the presenters are in the panel. So I'll now proceed with the introduction to the topic, and then I'll start to introducing the speakers, and I will start showing you the presentations. Also to remind people that we have links on the chat. The technician, oh my God, Andre, sorry, I forgot his name for a minute. Andre has posted the links to all the presentations if you want to go that way. But we will show you the presentations now in a minute on this on here one by one. But in terms of introducing the topic, it's an important topic. So it's been talked about this morning in bits and yesterday as well. So basically, much of our health and well-being is really depends on our socioeconomic circumstances. About if you look at between 40 and 50% of our health depends on our socioeconomic situation, basically. And one of these socioeconomic factors is employment. So for some studies, actually, a study from the US from 2016 shows that employment alone, employment alone contributes for about 10% of our health. So that shows that employment is very important for our health, important for our mental health in particular, and obviously for our self-esteem. Our identity is central to who we are, essentially. So that's an important. So there is a real connection between employment and health, very strong one. But there are many people with health problems and who faces also socioeconomic difficulties, and we need really to put in place the right amount of support and the right mix of support between health and training and other forms of support to help people to take their journey from where they are to employment. So the session today will look at how people with these problems may be supported in the journey back to employment, and the potential contribution of social prescribing to this. There is a report from a very useful report from the Work Foundation, which was published a couple of years ago, which looks at and shows the vast majority of social prescribing schemes still focus on health and clinical priorities rather than don't take into account employment sufficiently. So there is a strong kind of still strong emphasis on health and health priorities. So the major point, the last point I want to make, and then we can go on, is that obviously with COVID we have mental health problems and also employment problems with a lot of people who probably lost their jobs and experience mental health difficulties too. So there is probably now even a major, a more important argument for social prescribing and its potential role to support people into employment. So I'll see that's the kind of introduction. So I now kind of introduce the first speaker, and then I will kind of ask Tony to get ready to run the video. But Sonia Diaz is the first speaker, Professor Sonia Diaz, excuse me. She's a professional at the National School of Public Health, Nova University at Lisbon, Portugal, and coordinates the Public Health Research Centre there. So Sonia is leading a team that is evaluating social prescribing in Portugal, and her presentation is entitled Social Prescribing and Employment in the Portuguese context. So if you would mind to share your screen, Tony, and show a presentation, then we can then yeah. Just a second. Can I ask people to mute their mic? It's nice to hear babies playing, but maybe. Mm, mm. Do you have problem loading the video, Tony? Just one more. I mean, the presentation in total take about 35 minutes. So we still have, still have a bit of time, and we'll have sufficient time for Q&A still. But otherwise,
is it not showing?
No, no.
Sorry, excuse me. Sorry. It's not
No.
It's not working, no?
No. No, I'm afraid not. It's very strange because we tried this.
Yeah.
Anyway. Okay. Could I? Shall we revert to the other options? So.
Identify non-clinical needs, namely
Is it working
related
out?
to psychological, social, or economic.
Back to the.
It's working.
The professional makes an internal refer to the link worker, which in Portugal is a social worker that is a unit staff member. A social prescribing appointment is scheduled where the patient and the link worker develop a tailored intervention plan.
Go back to the beginning of the
And
presentation.
6 external responses provided by social local partners. The project is an integrated part of the activity of the health unit, and there is no specific funding for this. Taking a quick look at the first year of social prescribing, a total of 234 patients were referred to a social prescribing consultation. In terms of their characteristics, I can highlight that 66% of these patients were women and around 39 were between 18 and 50 years old. In the figure, you can see more clearly that a substantial part of the patients is their own active age. Also, I think it's important to highlight then that 43% were migrants and 28 are considered overusers of health services. Analyzing in detail the reasons for referral, the main reason was related to social isolation followed by sedentary lifestyles. But I want to highlight, and also for this presentation, that the reasons related to access to social benefits, to migrant social integration, and to employment and training constitute a significant part of the reasons for referral. Regarding the social needs of these patients, around 70% had 2 or more needs. So in total, 546 needs were identified as reasons for being referred to social prescribing. Overall, the needs related to access to social benefits, to migrant social integration, and to employment and training affect mostly women. The patients between 21 and 50 years old are the ones mostly affected by migrant social isolation and employment and training needs. Specifically for this population, younger and with difficulties of social insertion, including in the working context, there are several types of resources in the community provided by governmental institutions, municipalities, but also NGOs and associations and charity institutions. Overall, there is not a combined or joint response to social and employment issues. And this is a challenge for a more integrated response that I will mention next. But each one of these institutions offers specific interventions and initiatives, and I'm going to give some examples. So more specifically, at governmental level, the Employment and Training Institute provides a service to help find a job and also training for unemployment people. Other initiatives targeting especially migrants are the mentorship programs or entrepreneurship workshops that they conduct. Municipalities provide a more person-centered approach to help find a job with local employers as partners. Also, some NGOs organize courses for learning Portuguese for foreigners and also provide general counseling about these issues. And finally, regarding charities institutions, they assist in providing social benefits for employment people, for example, covering social integration and lack of income needs, but they also provide training and volunteer opportunities. Because the time is very limited, I would like also to finishing mentioning some important challenges that we face. First, structural and complex needs are often behind the reasons for being referred to social prescribing, like tackling economic deprivation or poverty. And for example, another example, from our experience, we see that the need for social integration of a migrant patient is frequently related to limit access to labor market and to social benefits. And indeed, this implies an integrated response approach based on a strong articulation between multi-sectoral resources that requires an effort that takes extra time and extra resources that sometimes it's difficult to have. Another challenge is that the reasons for referral are often heterogeneous. This diversity requires adequate and tailored responses that sometimes is not also very easy to provide. Finally, evaluating the impact of social prescribing can also be challenging, and one important difficulty regarding this specific topic is to conduct follow-up of patients who do not adhere or do not fully participate in their intervention plan. At the moment, we are coordinating the component of monitoring and evaluation of the social prescribing in Lisbon with the team that is implementing the project in the field, and Dr. Cristiano Figueiredo is the coordinator. So we work very close, and what we can say is that indeed social prescribing is a complex intervention, but that is promising in tackling social determinants of health. So thank you very much for your attention, and I'm more than happy to respond to any question later. Thank you very much again for giving me the opportunity to be here with you. Thank you very much.
Okay, thanks, Sonia. Thank you, Sonia. I will introduce the second speaker, is John Bell. He's a senior partner, a policy consultant, Curved Thinking, and has been active in employment, social isolation, and community development for many years. He has taken a close interest in the development of social prescribing since 2016. When he was one of the creators of Let's Get Working, and he is going to talk about that today. Let's Get Working. Well, he will explain it in a minute. So please, Tony, play his video. That's great. Thanks. Oh no, you came out now. Could you reshare that?
Talking about our social prescribing and employment.
Great.
Let's Get Working. And now Let's Get Working is a project funded by the European Social Fund and the National Lottery Communities Fund. And it's really driven from the social inclusion and labour market agenda. It's under the auspices of DWP. And so we came into this opportunity from the employability side, but saw an opportunity perhaps to link up with social prescribing as a means of trying to help with our remit, which is to move people with disabilities or long-term health conditions closer to and into the labour market. The project is delivered across East Sussex and Kent, and we'll be working with something like 1,500 people by the end of this year, more like 2,000 by the end of 2022 at the end of the project funding period. Now, the fund that we're supported by has very considerable flexibility in the way that organisations are able to go about delivering on their remit. And that flexibility was really grasped by SCDA to propose a project which was looking to test the potential for employment support to be delivered or offered in the context of social prescribing. Now, we made that link back in 2016 when the project was first being considered, because it was very clear to us that conventional employment support really does not reach, doesn't help an awful lot of people who could benefit from it, and particularly people with long-term health conditions with disabilities and so on. That will be familiar to many of you, I'm sure. SCDA and its partners have over the years developed a very effective, very well highly thought of working method to offer genuinely holistic support to people to overcome barriers to labour market participation. But there's also an increasing realisation that that addresses the wider social determinants of health and getting people towards employment. There's a whole load of other things that have to be dealt with. They turn out to be many of the same things that are social determinants of health that underpin much of social prescribing's philosophy, which is non-clinical interventions can help people to move forward. So we're coming to the same conclusion, which is deal with lots of different issues in people's lives. Our starting point being that as a route towards employment, social prescribing being that as a route to try and deal with the sorts of health conditions that clinical support can't necessarily reach. So what we might call social prescribing 1.0, the back in 2016, when it was really being driven forward by enthusiasts, by pilot projects, not part of the NHS strategic agenda, we felt that this could offer new means of finding people who might benefit from the sort of support that we have available and offering this in a sort of way. So our model is very much based on high caliber staff, very close relationships with participants, an awful lot of flexibility in the way that work is designed and delivered, and discretion in how to go about doing it. And a series of actions and aspirations agreed with participants that are really tailored to their circumstances, that are realistic, that embrace a wide range of different things that we're trying to do. Not just about stuff that's specifically work related, but dealing with all of those different issues that might get in the way of people moving towards the possibility of labour market participation. Ultimately, our model is all about trying to equip people to be active in the labour market, not to actually find them jobs. The idea is that they are then able to go and do that for themselves, with our support if necessary, but the onus is on people to take the lead. All of that was successfully moved online during the course of 2020, so we've straddled the pandemic challenge pretty well. As you can see from this slide, half of our referrals are coming from the healthcare sector, over 175 different organisations, most of them referring people to employment support for the very first time. And that's the sort of thing that we were trying to test. What's the potential for doing that? The people that we reached are pretty ill in the main. More than half of them have got 4 or more health conditions, a very broad range of different things that people are suffering from, musculoskeletal, depression, autism being the highest there. A long way from the labour market, 80% of the people we worked with are either not in the labour market at all or unemployed, over half of them from jobless households. And we have delivered some pretty impressive outcomes. 40% of people went into work when they left us a programme of support with us, 3/4 of them still working at 6 months, a quarter of people going on to some form of education and training. 68% reporting using the SWEB-WEMS measure a significant improvement in their well-being, 60% an improvement in health and community and social connections, and more than half improvement in their everyday living conditions. That success leads us to make a series of conclusions that the employment offer that we've made has appeal both to individuals and to the health bodies that are responsible for them. It delivers results. Social prescribing 2.0, where we are now, which is with social prescribing embedded into the health services strategic agenda, has, yes, legitimised non-clinical provisions such as employment support. It's stoked demand for that, but it's stretched the supply of the provision that's necessary. The employment-related route could broaden and deepen that supply to try and meet the needs that social prescribers are increasingly seeing and failing to be able to deliver because the supply just is not there. Our model works well with pretty much all groups, including those that are furthest from the labour market and the most marginalised, exactly those people that are going to be the most negatively affected by the pandemic. For this to work, though, if this is going to have legs, we need better dialogue between the different sectors. The employment support, the health, the care sectors need to be in better dialogue with each other. There needs to be a much broader appreciation of the multiple and diverse outcomes that can be achieved, not just specific bits of the agenda for the different funding organisations. And there is a need for sustainable supply-side funding for the social prescribing services. that's an incredibly quick canter through what we've done. I hope I've shown that we've achieved things, that social prescribing employment are very worthwhile bedfellows. And my colleagues, Jack and Jessica, are going to tell you a little bit more about social prescribing in Kent and some examples of what Let's Get Working in practice actually looks like. Thank you very much for listening, and do get in touch. We'd love to share our information much more broadly.
Thank you, John. Thank you for your presentation. It's indeed very impressive results, as some people posted in the chat, particularly, you know, because tackling the most disadvantaged and still managed to get very good results. I'll move on to the third speaker, who is actually kind of still talking about the Let's Get Working project, but in a bit more detail. Is just
Packman. I'm the contract manager here at
sorry, let me introduce her first. Thanks. So it's Jessica Bartindale and Jack Packman. Jessica is the operational supervisor for Let's Get Working project, and she's particularly interested in the link between social prescribing and employability. Her presentation is about specifically about one service user, Michael. So she really drills down, and quite interesting to look at the human side of this as well. Yeah, please, Tony, play the video now. Thanks.
That's Kent, and I'm with my colleague Jess Bartindale, and we're going to talk to you about what Social Enterprise Kent does with regards to social prescribing. Social Enterprise Kent was awarded the contract by Kent County Council and the NHS to deliver social prescribing and community navigation. SEC is partnered with Age Well East Kent, which are the Age UK's, Red Zebra Community Solutions and Carer Support East Kent to deliver a 4-year contract, which Social Enterprise Kent are the lead organisation. The service is available to all in East Kent who are aged over 55 and to those under 55 who have a disability or health condition. We are very well linked in with the healthcare sector. We are involved with the local primary care networks, where we attend local MDTs, where our community navigators and social prescribers sit on the multidisciplinary team meetings. We have direct relationships with GPs and GP surgeries, and 30% of our referrals are from an NHS source. I'm now going to hand over to my colleague, Jess Bartindale.
Thanks, Jack. My name's Jess Bartindale, and I'm the operational supervisor for the Let's Get Working project, which John talked about earlier on. Let's Get Working is an employability project supporting people with disabilities and health conditions. Let's Get Working is also a social prescribing research project, so therefore we encourage referrals from a wide range of healthcare professionals. We seek to work collaboratively with these healthcare professionals to get the best for our participants. And I'm going to give an example today of how we've worked in collaboration with the neuropsychology team at Kent and Canterbury Hospital. We do have lots of other examples of this, so if anyone's interested, please do get in touch. So back in 2017, my predecessor did a presentation to the neuropsychology team at Kent and Canterbury Hospital. It was really successful and the team bought into the project. Ever since 2017, we have regular referrals from neuropsychology and have had a really effective relationship with the neuropsychologists and the community connectors. As I say, we really seek to develop a collaborative approach, and this involves the neuropsychologists and the community connectors, who are the people that work on a one-to-one basis with participants. So they do face-to-face meetings, but also the neuropsychologists have been able to provide telephone support for our community connectors to be able to sort of find out as much as possible about those participants and about their very specific needs that we wouldn't necessarily be able to do. We're not medically trained at Let's Get Working. So the case study that I want to bring you today is a gentleman called Michael. Michael is 50. Michael used to work as an electrician for, I think, about 20 years. He suffered a stroke which affected his left side, and it gave him issues with speech, affected his cognitive abilities, his balance, fine motor skills, and his memory. Michael was referred to us by neuropsychology to help explore what he can now do, and also what his limitations are, with a view to going into employment in the future. So we did all the sort of things that you'd expect an employability project to do. We looked at his cover letter, CVs, interview techniques, but also because we were working collaboratively with his neuropsychologist, we were able to do some very specific work with Michael to help him with the limitations that he was facing. So that we did specific memory games, we did a skills analysis, and various other work. It was quite sort of slow going, but really rewarding, and Michael got an awful lot out of it, and you could see the progress between meetings. We helped Michael to get into a couple of different volunteering roles. One was a gardening role at a local castle, and a second role was a sort of repair shop type thing, where people, for example, bring in their broken toasters and the people in the repair shop mend them. And it's a sort of community project, so to encourage people to talk and be part of the local community. By the end of the project, Michael was making his own phone calls. He had a massive increase in self-confidence because he had really struggled with communication, and this made him quite angry, but he had a massive increase in self-confidence. There was a real improvement in his speech. He'd improved his writing, so his fine motor skills were developing. And what was really lovely is he gained back his sense of humour. When he came to us, he was really quite angry about what had happened to him, but actually this eased over the time that we worked with him. We worked with Michael for about 10 months. And he left us last year, just after the COVID sort of breakout in March last year. What's really lovely about this case study is it demonstrates this how successful a strong collaboration can be between the NHS bringing in their clinical sort of professional expertise with the community, voluntary and community sectors, and with us bringing our employability skills and experience to that. So that kind of merge of skills was what really helped Michael develop, and that's something that we would really like to explore more of. We are trying to work collaboratively in this way with lots of other organisations, and we are making some real successes in that. But this is a lovely example of why we want to do that. So Social Enterprise Kent will continue to develop links between social prescribing and health through new projects and initiatives. We seek to strengthen relationships with the healthcare sector to promote all aspects of social prescribing and the importance of developing this in local communities. So please do check out our website, get in contact with us, and follow us on social media. And also thank you to Marcello and Tony for chairing this session. Thanks for listening. Bye.
Thank you, Jessica, and very powerful case study. A couple of things really interesting. How the significant improvement in Michael's emotional health, and one of the things that sticks out is also the requirement of support needed to help Michael, which might be something that we can look at later. But let me introduce Jayne Garner, the next speaker. She works for Ingeus and is head of delivery for the Working Well program, a work and health program based in Greater Manchester. She's got more than 20 years experience with employability programs. She worked with this program with Elemental, the software company, the social prescribing software company, I should say. And so over to Tony to present this one. Yeah, it's appearing on screen now. Thanks.
For this section, Marcello and Tony. I'm Jayne Garner. I'm the Head of Delivery for the Working Well Work and Health programme in Greater Manchester, and here to give a little more information about our approach to community referrals and social prescribing. First of all, a bit more about our programme. We're not a social prescription programme, we are an employability programme, and the largest of its kind in the region. So we expect to have 22,500 people through the programme across its lifetime, and another 13,500 people in response to COVID over the next 12 months. For our core programme, we expect the majority of people joining to have a health condition or disability, and our participants spend 15 months with us on their journey towards work. Our main aim is to move people into sustainable employment, and absolutely recognise that we can't do that alone. Our programme focuses on strong integration with our local communities and a range of experts to provide support to people to help them to move forwards. A bit more about the people that are joining the programme. So 35% of our participants are long-term unemployed, so haven't worked for 6 years or more, some of which have never had a job. For all of our customers, they have barriers to work, and they range from their health conditions. More than half say that their health condition could affect their ability to get a job. More than 60% have a need around skills. Confidence is a key barrier, and of the health conditions that people present with, anxiety and depression are by far the most common. As you may expect, our participants are very likely to have a combination of different barriers, and almost half of them tell us that they have at least 3 things that are preventing them from moving into work. For example, being long-term unemployed increases the risk of poor health, and those presenting with physical health problems or living in pain may be experiencing an increase in mental well-being concerns. There are the long-term impacts of COVID and increased levels of isolation, increased instances of people struggling with their mental health, and coupled with a rapidly changing labour market and a range of sectors that have declined rapidly over this time. A bit more about our approach. So for us, the key worker is the golden thread in the customer's journey, and they're there to facilitate interventions that provide a tailored approach to what that person needs. We employ a team of health professionals, including psychologists and physiotherapists, and they access a range of wellbeing resources, as well as providing support on a one-to-one and in groups. And that team's been in place since 2014. But for this programme, since 2018, we've embedded an integration team, so integration coordinators in each borough of Greater Manchester, and their role is to engage with services in the community and make sure that we have those relationships in place to provide services and interventions for the customers on the programme. Independent evaluation shows that our health team and the function of the integration coordinator role are core strengths of our delivery. We have a strong ethos that work is good for you, and again, completely recognise that we're not a social prescribing service, but a lot of what we do has similarities in that approach, and we're really keen to learn the lessons of social prescribing models to apply to the way that we deliver the programme. Some of the key similarities that we see is that holistic assessment of need, which helps us to identify barriers and the right solutions through tailored action plans. We look at a range of physical and mental health support through our own delivery, but also what's available in the community. We support people to work on personal and social barriers, debt, housing, isolation and bereavement. And we work with a range of partners to address needs. Some of those are statutory services, some of them are local initiatives, and we work with a range of charities and voluntary services to get people access to support in their own community. In the last 3 years, we've made more than 48,000 referrals into community support. Some of that is signposting to available initiatives, and others are more streamlined referrals directly into an intervention. The most recent development for us is that we are the first in employability to partner with Elemental in order to utilise their social prescription software, so that there's a very streamlined approach to the referral. The benefit for the customer on the programme is that once a need is identified and in that conversation with their key worker, a referral is immediate, so needs are addressed very quickly, and we're keen to make sure that we're accessing the right support at the right time. For the partners, it's a great way of making sure that referrals are streamlined, safe and secure, but also that they're directly relevant and eligible for the services. We're keen to encourage others to join that approach and can register their on our website. At that point, I'll hand back over to our co-chairs. Thanks very much for your time.
Yeah, thank you, Jane. Very interesting presentation. It's more of an employability scheme, but still very useful to look at how social prescribing might be working with the employability scheme in the future, perhaps. I'll now move on to the last presentation from Karen Sankey. Karen Sankey is a GP with over 25 years experience. She's passionate about tackling social injustice, health inequalities, and wider determinants of health, particularly engaging and listening to individuals who use services to understand how best to improve interventions. And she will talk today about the drop-in service for homeless and rough sleepers in Wrexham, Wales. Very interesting piece of work as well. Thanks. Please play, Tony, and then we'll get to the Q&A session. There are quite a few questions, actually.
Thank you so much, Joe and Tony, for inviting me to speak to you this morning. I'm Karen Sankey. I'm a GP that's been practicing in North Wales for the last 25 years. I have been asked to share with you some of the work that I've been doing with homeless people, developing more holistic services. So my journey started 5 years ago when I became interested in health inequalities and social inequalities and how we could design services that would address wider determinants of health. I started thinking about holistic wellness models as opposed to the traditional illness model, and how we would create services that addressed not just the physical and emotional needs of our patients, but also the social needs. I'm very interested in the root problems and why people end up being unwell or presenting to us in crisis, and started thinking about how we would go further upstream, working with people to understand their needs and offering services that were more preventative and acting, focusing on early intervention. So I spent a long time consulting with all sorts of people and came up with a list of key principles I felt were needed and really important when thinking about a new service design. And then in 2017, I was really fortunate to be invited to meet with people that were homeless in Wrexham and either sleeping on the streets or rough sleeping. And I spent some time talking to them and trying to understand what it was that they needed. As a result of that, we set up the Community Care Hub, which was a weekly drop-in service. We did this in partnership with Salvation Army. So every Friday morning, we had an open access multi-agency drop-in service that anybody could attend, anybody who was vulnerable in crisis. There were no eligibility criteria. So the service started with a very much a deficit approach. All of the people we spoke to had three key priorities. They were struggling to access GP services, struggling to access mental health services, and actually struggling to find and secure safe accommodation. Over the 3 years that we ran the hub, it became more aspirational, and at the beginning of the COVID pandemic, when we unfortunately had to close the hub, we had over 30 agencies attending every Friday morning. So we created a care navigator role. So these were our front of house team, really diverse team of people that worked with people attending the hub, and essentially did the signposting, social prescribing role of linking people into the appropriate services. So whilst we had a lot of medical services present, we also had lots of other non-medical interventions and other non-medical services that individuals could be signposted to. The hub model was extremely successful, so we did lots of feedback sessions with people using the hub, and every single person said that they would be better, they'd be worse off if the hub didn't exist. It also works really well for all the agencies, so we found that there was a reduction in duplication of work. We could turn around, for example, sick notes to getting a benefit decision historically was taking 2 to 3 months. This was now taking 10 minutes. Police reported a 43% reduction in criminal activity, and we had a reduction in urgent ambulance use, as well as a reduction in DNA appointments in secondary care. When we analysed the service, despite all of that, it still wasn't enough, and so sort of based on Maslow's hierarchy of need, I identified that there were sort of 3 key areas that people need to live a good life. That is somewhere to live, someone to love, and something to do. So we started the second phase of the project looking at how we would address these 3 areas. So we started doing workshops with people using the hub. Every Friday we'd have lunch with them and talk to them to understand their journey, understand what they needed. And these are the 6 areas that they felt were required. So based on the information they'd given us, we then did a piece of work. We created a peer mentoring service. We started doing social activities. We set up time banking, so we do trips to the cinema, trips to the theatre, trips for lunch, and we had huge success. So these are 3 of the young people that we worked with who have gone on to all take volunteering posts. And yeah, we're really proud of them. So that's me in a nutshell. So thank you so much. I'm sorry that was really speedy, and I'll hand you back to Marcello and Tony. Thank you.
Thank you very much, Karen. It was very important very important case studies as well. So it really brings it to life. You know that of course the journey to employment has many different stages, and some obviously, if you're homeless, the first most important thing is to find a place to sleep tonight, kind of thing. So it's very important to highlight that. We now turn to the kind of more Q&A session. There are quite a few questions. I'll go in a sense in order. So the first question from Julie Pollard is: do you have an enabling fund to support patients? So I imagine she means funding specific for social prescribing and supporting people into employment. I'll ask the panel first, and then maybe I can comment later. Is anybody who knows of specific funding for employment? No. Not. So I would say.
Do you mean?
Yeah.
Sorry, Marcello. Do you mean
yeah.
like a funding program for employers?
Well, a funding program to support social people into. I guess what Julie is meaning is that is there a funding specific to support patients into employment? So I guess supporting social prescribing, like Let's Get Working, for example, to get people, to move people into employment. That's what I mean. I think is not terribly clear, I'm afraid. but that's, I think, what she means. John?
So I can chip in, Marcello, if that would help. I can clarify.
Okay.
It was really just a question around acknowledging that commissioning in the voluntary sector is often short term. So with the Building Better Opportunities funding ending in 2022, what's the plan to try and embed the learning from these programmes into future sustainable models? That's more what I meant, rather than specific funding that might be available to continue it in the future.
Okay, thanks for that. Yeah, John, perhaps. Yeah.
Yeah, sure. Obviously, we were able to bring together the Building Better Opportunity funding with the opportunity for social prescribing. So, we had the money potentially available, and it was by saying we were going to link with social prescribing services that was one of the persuasive things that enabled us to access that funding stream in the first place. So by presenting this to a fund that was not actually involved with social prescribing, but they understood the potential. And so that was our way in the first place. Now, fortunately, BBO has continued on for a period of time because there is some underspend, and it's the strange dying days of the European Social Fund means that it's going on and on and on. What we're doing at the moment is really trying to find how that might continue into the future. I think one of the big opportunities really is trying to link up at a strategic level where there are funds. There are new work and health programme type services being tendered at this very moment. This week there are bids going in from Ingeus and amongst others. Some of the formal links between those funding streams is what's needed. Voluntary organisations can go about and try and cobble together small bits of funding from the traditional sources, and that's great if you've got that available locally. But one of the things we would argue for is that a much more strategic level linking up of large policy stream funding, such as COVID recovery, with other big streams like social prescribing, and trying to force them to pay more attention to each other.
Okay. There is also a very important point made about the role of link workers and the expectation of their role. I think there were a few comments in the chat around, especially, for example, Amanda Priest. She says, I don't think we can expect link workers to be experts in employment support, but rightly refer to the appropriate support and the ability to recognize the need is important. Yeah, and this is an important point about what is the role of the link worker in these particular circumstances when employment is concerned. Where are the boundaries and how you integrate? I don't know if you can comment on any of this, any of you.
I think for me there is there's a really clear link, a synergy between the type of work that our employment coaches and key workers are doing and the way that community link workers will work in the community. And look, for us, not everybody will join our programme. Really, the programmes are geared up for people that are benefit recipients and that maybe have a conditionality or requirement to look for work as part of them claiming benefits. So the vast majority of people coming through to our programmes are claiming a benefit that has an element of conditionality. So just that recognition really that there are many, many other people that are unemployed and not accessing that support and maybe not claiming benefits, either because they're not eligible or they choose not to. And, that means that there is all of these pockets of people in the community who may be not gaining that support right now. I think we've got a really good opportunity, and we do this to a certain extent now in Greater Manchester, of making that connection with community link workers to share some of the services that we are integrated with, that we refer to, that's visible through the software that we're using. So there's one way of doing that digitally, and there's another through just those human relationships and making that connection. And we're keen to share that back the other way. But while somebody's referred to the programme, they're our responsibility. And just to sort of touch on that funding point as well, that we have a small pocket of funding, a community investment fund, we call it, that's part of our programme and is built into the budget of our programme to support voluntary and community sector organisations to deliver particular interventions if that's identified as a need or there's a gap in community services. So there is small pockets of funding available to us, but I think more broadly, you know, there are some people accessing these programs and others that just are not eligible. And it's having that reach in the community through healthcare services is so important.
Thanks, Jayne. Is there anybody else who has any comments to make, or otherwise I'll move on to a related question. Anybody else has any comments on this particular point?
Just very quickly to say, I think we would argue that although our staff are very flexible and do many, many different things, they are employment specialists. And I think we would argue that if somebody has a very well recognised employment need, it's worth referring them to a specialist, because there's a lot of different aspects involved. It's quite complicated. You know, you wouldn't expect a medic to be able to give somebody employment advice. Equally, you shouldn't expect it the other way around. So I think link workers have a tough job. The really important thing with them is that they know the variety of different things that are available and are primed to think, is employment a valid possibility for this person? If so, where can I send them? Because going down that route brings lots of other benefits if you can make it work. So link workers have to be generous to an extent, because they need to know the scope of what's there. And the important thing is to get employment recognised as one thing that should be being considered. I think that's what we would say. Okay,
thank you, John. Any other comments on this point? Otherwise, I'll move on.
It might be worth pursuing. Yeah. Marcello, I'm very conscious of the role of employers, either small employers or middle-sized or whatever. I'm particularly conscious of the work that that Karen has undertaken with the homeless and how people end up in either volunteering roles or potentially in paid positions. And is there much work done, you know, to encourage employers to adopt more empathetic approaches and so on? Karen, could you come on that?
To us, this is an area we're actually looking at. In the hub, we created a pathway for people that were using the service to become volunteers. So we actually had some of our volunteers were actually sleeping on the streets, but on a Friday would come in and have a role in the hub, which was really successful. And then we created an opportunity where we actually took 2 of the people that had been on the streets. After they volunteered for a year, we actually gave them employment, and they felt very safe because they were obviously in a protected environment where they were very well supported. And that was a model that we were wanting to develop further. Unfortunately, COVID meant that the hub has had to close. And I've actually moved now to a new role where I'm trying to sort of set this service up again. But we're having some conversations where I'm working now with the business networks about how we could actually then link in and have this almost pathway for people, vulnerable people, to almost lead them back into employment. Yeah.
Because I would imagine retention of employment could well become a difficult concept as well for employers as well as for the employees. So that relationship would need to be nurtured and facilitated, I would imagine, for quite a time span.
I think the concept we're looking at the moment, we're creating the piece of work I'm working on now, which is really sort of the follow-on from what I did at the hub, was I'm trying to create a wellness service, which is rather than an illness service. So as a GP, offering that sort of wellness support, coaching, and the personal development aspect, and a lot of that around very trauma-informed approach. Most people we're dealing with have had significant trauma in their past. So what we're hoping to do is wrap almost that package of support around an individual as then they go on their journey into volunteering and employment. So that's a continual piece of support they have, because I think that's the problem we find is people have an initial period of perhaps 6 weeks, a few months support, and then they go off into the big bad world and then they relapse. So it's actually how we keep that continuity. And so we're looking at a community mentoring scheme and a support system that will stay with people for as long as they need that.
Okay, thank you.
Thank you, Karen. I'm conscious of the time, so I would like, we're at the end of our session. I would like to thank all the speakers, Tony, and all people who attended. And I just would like to also point you to, obviously, the networking lounge And also there is in the networking lounge, actually there is a table with social prescribing and employment. So if you want to further your conversations there, and apologies for those who have posted questions and we couldn't answer, but I made a list and we'll try to send you perhaps, yeah. I don't know what I'm supposed to do with that actually, but apologies. So anyway, thank you all for being with us, and I hope it's been useful. And see you later. Bye.